Was an interpreter used?
I didn't see any mention of an interpreter used in her office notes from this particular pregnancy, either at her intake or on the postpartum visit. They gave her Depo-Provera at that postpartum visit, and then talk about potential issue or something more permanent, but that was left open-ended at that time. In terms of her 2005 delivery or her 2006 termination, I don't have any more information about that.
I think that Dr. Goldsmith is right in terms of the initial failure here was a failure of contraception, but I think subsequent to that, there seems like there was a failure of prenatal care in terms of, a woman who sounds like she has a history of peripartum cardiomyopathy, although, as in anything, there's always a question of what exactly is the etaology of her heart failure, especially with this family history of heart failure, but she sounds mostly like peripartum cardiomyopathy who wasn't cared for like somebody who has peripartum cardiomyopathy and potentially wasn't counseled appropriately for her risk of recurrence of that event in the postpartum period.
I think from my experience looking at cardiac cases in maternal mortality, this is a prototype case. This is a prototype case for cardiomyopathy of any kind. But this particular, you mentioned earlier, with the family history, brother dying at age 19, makes you think of a familial type of cardiomyopathy, but it doesn't matter at this point. I think the important thing is that she had cardiomyopathy, was in congestive heart failure with a prior delivery, and then there was a loss of follow-up, kind of no medical care. Now she presents late into prenatal care with that history. I think that is the point where you could have helped, or there was an opportunity not only to get all those records in a timely manner, but counsel her right there and then from there on, she had more than one emergency room visits. So I think this is again a failure, or there are several points where you could have intercepted, helped, prevented this unfortunate event.
I was stunned when I saw that her first visit at 35 weeks, so she's presenting very late, she's saying she has congestive heart failure, and there was no referral.
Right.
Yeah.
And I think, what I was imagining was no translator, a woman that the providers were having a very hard time communicating with. At that point, knowing that she hadn't come in until 35 weeks, she needed a whole host of things happening on the medical side of things, but also on, I don't know when they learned about the IPV, but in terms of social work getting involved and a home visiting service, because she has this history of not following through.
She went to a private OBGYN's office, and so, there was a nursing intake, and then there's 3 visits with the provider. And patients, even if anybody that, it's not normal for a 30-year-old to tell you that they have a heart condition, and if they say that, especially if they know something as specific as congestive heart failure, I probably wouldn't spend a lot of time thinking about, I wonder if that's really true or not true, especially time is of the essence at 35 weeks. And, you can probably at least get an echocardiogram. Sometimes it can be hard, maybe, depending on where you practiced, to get a referral in or this or that. But at least if you get the echocardiogram in and realize kind of what you're dealing with, if it's markedly abnormal, then at least you have some, you're going to manage, I think, her labor differently in terms of fluids and all that sort of a deal.
Absolutely. I think in this case, it was starting from the interconception period, before she presented to rehab areas to improve. Then when she presents for prenatal care, there's another opportunity to look into. And after she delivers, she had this history, and now she delivered with this history of cardiomyopathy. And we know that these patients, cardiac patients, may get worse, not necessarily during delivery, but after delivery. So that was another opportunity. Particularly, she had complaints of cough after she delivered. So that was a red flag right there. And then
if you look at her I's and O's too, she was positive 3 liters at the first 24 hours, which.
certain appointment. So if they're wondering about it, what she delivered in 05, and now this is 10 years later, so at what point?
Well, typically in a patient who has postpartum cardiomyopathy, if they recover, they usually recover in the first 6 months. So if she had a follow-up echocardiogram within the first year and her ejection fraction was not normal and she was off of medications, she falls into a separate group, which is a better prognosis than somebody who has persistent LV dysfunction, which I suspect this patient was, because she practically was symptomatic at the time of delivery. So that is the group of women where the mortality approaches 20-25%. So this is the group of patients where pregnancy is contraindicated. That's why she had that termination in 2006. And if she gets pregnant again with LV dysfunction, you have to again discuss pregnancy termination and follow in a multidisciplinary fashion.
So the point that I wanted to make with respect to the interpreter, because I've seen this happen a lot of times with patients, is they might memorize a buzzword, but it doesn't necessarily mean that they understand it. Will look you in the face and go like this. Families translating for them. I mean, there's a reason why you have to have an appropriate interpreters, because they're not going to be able to convey the medical terms. And in looking at how poor the postpartum discharge instructions were, when you're thinking about the acuity after delivery, it just feels like such a recipe for disaster.
There was, and I think just to tag along on your postpartum instructions, when you look to see that there were no special problems noted, nor were there any postpartum instructions, special instructions provided, due to missed opportunity, because even if there wasn't as much recognition, I don't know that there wasn't any recognition of history with cardiac disease, but to know that should you have any case and any of the symptoms that you need to come back immediately prior to the 2-week visit, whenever it happens, it's important not only for her, but also for her therapist to recognize that, to assess. So there was
And expanding on the same part, she actually did present to the emergency department more than once.
and then
We didn't treat her right.
so did she share with them that she had been pregnant, so did they know she was pregnant, or did the provider go to even ask that question?
So that is the point of the cardiovascular toolkit that we worked on. Pregnancy within the last year, ED, those that if they delivered and they come in with some brand of asthma, those are the triggers.
Can I ask Dr. Hamid just a quick question about sort of the actual cause of death? I mean, I was a little bit confused just in terms of how the MI plays into this whole picture. I mean, in some of the documentation, they say like she had an MI that resulted in, her cardiomyopathy that resulted in her death, which doesn't seem correct, with all the information.
Seems like the other way around,
information we
yes.
have.
I
So,
agree. I think if ejection fraction falls down to 20%, for those of you who are not familiar, EF is upwards of 55% in a normal person. So when it falls down to 15%, that's when you look for transplant. Those are transplant candidates. When you get to 20%, these are women or patients who are really symptomatic. They are on multiple medications at risk for sudden cardiac death. So they are the super high risk. So the sequence of events that seems to happen here is she went into heart failure and she was in cardiogenic shock, which was the extreme. The only way she would have gotten out of it is if she responded to the intra-aortic balloon pump, or she was left ventricular assist device or transplant. Otherwise, there's very little chance. And particularly with malignant arrhythmias, these patients don't do well. In terms of the coronary, I think those are, I agree with you, I don't think those are the primary reasons, because initially she had her troponins done by MV fractions. There was no initial evidence of a myocardial damage. So even though that can happen in pericardial cardiomyopathy, so there was no big myocardial infarction that put her in. For you to have cardiogenic shock with myocardial infarction, it would only be if literally all 3 or 2 of the big vessels, they get blocked and there's no perfusion to the heart. And your troponins will be sky high and you'll be a different patient. So this is primarily cardiomyopathy.
And what are the recommendations for anticoagulation? And she did have 2 little spots in her left circumference.
Absolutely. So when the ejection fraction goes below 30%, your cardiac output is not that great. So you tend to have stasis, you tend to have not only venous thromboembolism, but you may also have a thrombus inside the heart, which is the LV thrombus. So the recommendation is to give them anticoagulation to prevent those complications. But in this particular case, I don't think that primarily led to the demise, but again, I think that is what was lacking in terms of the flow.
So my question as the non-medical person here is, we know that she died from this cardiac set of events, but was it that, is it that what killed her, or was it the system failure to properly treat her? So that if, when she got there at 35 weeks with no prenatal, well, one would hope that there would have been follow-up before that with this woman, but getting to prenatal care at 35 weeks, if like at that point, the physician had referred her to a tertiary care hospital and a team came in and
And what are the legal requirements for translation services?
It's required.
It's required. You're technically, in a hospital facility, you're supposed to provide one. That's why I kept asking.
Medically trained.
Yes.
Yeah, medically trained.
Yes,
Yeah.
yes, medical training can't be the family. It's not supposed to be the family. Well, that's why you would require a medical.
There's not so many French speakers.
But the person doesn't necessarily have to be, person doesn't have to necessarily be there in person. You could do it through like Skype wise or telephone. There's different options. Ideally, if it's during the delivery, you would want to have somebody there in person, but that's not always the case. There's a lot of technology now to make it happen. And if she had a planned induction, then you had enough time to coordinate all those services.
Well, French isn't a difficult language. I mean, we have in our, you know, in Columbus, you know, like Fulani language, there's one Fulani interpreter in the entire city, you know, so that requires, you know, a lot more.
And that's part of,
What about a private doctor's office? Is that different from a hospital? Or my understanding is even if you're a private doctor's office, you still have to meet those standards in
you
terms
still
of
have that duty.
interpretation.
And so that,
From the legal standpoint, how do you determine that this patient needs an interpreter versus not?
so if you're, so I'm going to play devil's advocate. A couple of people mentioned how many times she talked about congestive heart failure, right? But yet, the way that she treated her pregnancy and the lack of follow-up can lead you to believe that she didn't have a full understanding of exactly how to manage this. And how can you say that you properly educated the patient when you don't speak her language and you didn't have anybody there to be able to say, hey, I communicated with her in French? You don't have any documentation of that at all.
We better pause here. This is a great discussion. We, you know, but we have another case to do, so we should probably take a look. And I think what we're going to do is go to our audience and let them vote, and then we'll make our deliberation, and then we can see the comparison.
So I'm hoping too that everyone is feeling like that this is much richer than just administrative data, right? Okay, so make sure that if you have a clicker, not everyone has one because we only had 40, make sure that your clicker's on, turn it on. This is gonna take us just a few seconds. So one of the key decisions that the committee needs to make next is whether or not this death was pregnancy related. Deb, is there anything more you want to say about that definition? Do we need a reminder?
It's on your paper. It's at the bottom of your paper. So remember, it would be a death that you could attribute to the pregnancy. One of the things that we say in our teams a lot of times is, if you're not sure, would this woman have died if she had not been pregnant? And that's a key clue to how you might determine. Just another way that you can categorize the pregnancy-related deaths. So we're going to lump them both together for this purpose. And
Yeah. What about an opportunity to alter outcome? Yeah? Strong. Okay, so we agreed with our audience, so that's good. So in the interest of time, I'll just say, I think, do we all agree with the cause of death being secondary to cardiomyopathy? No one who didn't? Okay. So what about recommendations? We'll take a couple minutes just to say, what would our recommendations be? What's that? Yeah.
Any question for pregnancy for ED residents?
Yes.
And another thing that's helpful with the EMRs is that that chart could have been flagged. She's had various visits to the ER, so it could have been part of the problem list, history of so-and-so, that would have, didn't matter if I never saw the patient before, it would have popped up, and it would have become, hopefully, part of your assessment and plan of care.
So there were really, if you look at these kind of things on 3 levels, at the patient level, at the clinical level, and at the systems level. At the very, at least there were certainly a lot of clinical issues that we identified, not just among the obstetrical providers, but also other disciplines. Anesthesiology, they had an opportunity on labor and delivery to intervene, as well as the emergency department, but also systems issues, in terms of translation services and maybe accessibility of records. I will say for the group that this lady's, all her deliveries were at this hospital. So the records from 2005, 2006 were at the hospital, so it shouldn't have been that hard to make a records request. And the cardiologist who saw her during the second ED visit at the primary hospital was her cardiologist. She was known to him. He knew her as soon as,
Another major issue is family planning and access to long-acting reversible contraception. We don't know
Right.
what her intent was with pregnancy. We don't know what her relationship was with her husband at the time, whether she was allowed to but if she had, with interpreters, she would still get graduate situation. If she chose to get pregnant again,
right.
all this is prevented.
Yeah, and I will mention just bring up again the intimate partner violence. I mean, she had a restraining order against him, so we could only assume that it was not a great relationship.
I think that one of the reasons to have a community-based organization on your review team is that we also have to look outside the walls of the hospital, and there are 2 really big systems issues here. One is the education of private providers in terms of how does a city or whatever area that is that this took place in get all of their providers to know that if this presents, you need to get the person someplace else. And then I think the domestic violence, we don't know. One of the things that in our committee we would have talked about was what were the services that would have been available for this woman? Do we need to look at, for example, services for women who only speak French? Do we have that available in our city?
Yes, exactly.
And
So,
I think that's very important to our assessment and referring to her as non-compliant. Based on the medical records, we don't know if she was prevented from going to prenatal care
Right.
earlier than this or what the other circumstances were. And so I think that sort of a perspective is important.
she got that tag, but it was probably a lot more complex than that, so.
And I just want to point one thing out real quick before we move on.
Yeah.
So just because we're kind of a little bit rushed, we jumped ahead of a really key part, is really identifying by the team what was the underlying cause of death for this woman. So do we have a consensus as to what we think was the underlying cause of death? The peripartum. And so I want to point out to everybody in your packet, there are the PMSS-MM codes, which are the maternal mortality codes. So I highly recommend that if you're not using them, that you take a look at them, because it's a great way for data to be collected uniformly among many states. Okay, so there
So
would
if
be
you're
a code.
comparing, if we all compared all of our cases with each other around the table, we all do that. And I'll also put in a plug when we think about recommendations, a toolkit that California's putting together can be very beneficial to just about any state, But, so.
I would go back to those postpartum discharge instructions, making sure there's something and it's written so they can take them home. So in this case, someone else could have.
Okay.
Just one other issue, this case. Her sister had adopted out. She had adopted out 2 of her children and was supposed to adopt out this 3rd child to this woman as well. And you're just looking at the whole system's failure. There's something really significant going on here.
Yeah.
Why is she having these babies? Is she having them for herself or is she having them for her sister?
Yeah.
Can I break in here? So I know we have people chomping at the bit to ask some questions and clarification. So I want us to take just a few minutes to field some questions from the audience. The committee's all warmed up. I know that you all would have probably gone much, much longer on this meeting.
Well, in our review, we would say, you know, we would try to do this in 20 minutes. This case may have taken a little bit longer, you know.
Philadelphia, we schedule about 5 or 6 cases for a 2-hour meeting. And also, because you can never predict that sometimes the more we do pregnancy related as well as those not related. And sometimes you assume that a pregnancy related case is taking the majority of time, maybe like 10 minutes. And then something totally not related, we'll spend like 30 minutes talking about it. And it's
Yeah.
something to facilitate to keep it all.
And we sent the cases out de-identified to the members ahead, so they've read it, so it's not like a cold thing. They've had a chance to think about
I
it.
think that's ultimately the goal for us at the end of every year, is figuring out what are our recommendations legislatively or to physicians.
There's also something to keep in mind with, I mean, if you've done femur before, if you're looking at mortality review, you can do an interview with the mother. In this case, the person who died, the person you're reviewing is dead, and you won't know the story. We're trying to get to the bottom of the truth, and there's always so many questions, and sometimes, and when we review our cases, sometimes, and we'll try to talk to the doctors to keep anonymity. In Philadelphia, there's only 6 labor and delivery hospitals, and so we have all the chairs there, and so they'll know the cases, and we'll talk to them before we review it with the group, so they can give us feedback, stuff that we don't get out of the extraction of medical records. And sometimes the medical records may say one thing, you know, was someone transcribed, you know, because of non-compliance or this or that, but maybe it's not as simple as that, and it's hard. And we don't do follow back, you can't do follow back, but so you're trying the best you can.